Okay. Good morning, everyone. It's a pleasure being with all these experts here in this symposium. I would like to thank Marcio and all the group that create this very active symposium. We are going to have a great opportunity this morning to hear from the experts about Myval and novel technology in TAVI. So it's time to start, and it's my real pleasure to present the pioneer, Dr. Alain Cribier. That's a very good friend for us. And it's a pleasure to have you here, Alain. And time goes fast. It's almost 20 years since you did the first TAVI case. And now we are here to discuss a new technology. Thank you very much, Alain, for being with us. I still remember when you were with us. Please turn on your mic. Okay, great.
Yes, well, okay. It's a real pleasure for me to be with you and to share this wonderful session. And I can see on the screen many of my friends, including Patrick Serruys, that I have not seen for a long time. Hello, Patrick, how are you? So, well, if you want, I was asked to discuss a little about the concept of balloon expandable valve. And so I have a few slides. If I am too long, you just tell me. First of all, this is the title of my presentation that I was supposed to speak of, Crystal Ball Gazing, TAVI Balloon Expandable Technology. And I would like to remind you that we did the first case using a balloon expandable technology exactly 19 years ago. You know, the anniversary was yesterday. So I think it's a great opportunity to be with you today. And you have here a little picture of this very first case.
Professor,
yes, I
you may
in full screen. Is it okay?
Not yet.
You will need to share your slides, so you can go to the Present Now button at the bottom right of your screen, and that allows you to share your screen.
Wow. I thought you had it on the...
Like you did a little while ago.
Yes, but...
Slides, so you can go to the present.
I am absolutely sorry because I click on Présenter Now and I don't see the partage d'écran partagé. If I do that, do you have it on your screen?
No.
No. Well, it doesn't work. I don't want to take too much of time, you know, so here. And now, do you have it? Now?
Unfortunately not. Yes, right now.
Is it working? Okay.
Yes, it works now.
This little problem that I had. So just to remind you that, you know, this first case was done with a balloon expandable valve. And I just would like to tell you a few things about the balloon expandable concept. So where are we today? There is an incredible expansion worldwide of TAVI, as you know, with about 1 million procedures in 70 countries. And the expected growth is of 40% per year. And in USA, the TAVI market exceeds the surgical market. So this is something that I wanted to stress a little. So when we consider the two valves that are globally the leader of the field of TAVI in Europe, you have the Sapien 3 today and the Evolute from Medtronic. And in Rouen, for example, we are implanting 80% of Sapien 3 and 20% of Evolute. In France, in general, the ratio is 60/40, and in USA 60/40. And the self-expanding offer leads in other countries, mainly for marketing reasons, and because it is proposed at a lower cost by Medtronic. So a selection of TAVI valves by the Rouen Pioneer team in our department. The Sapien XT the Sapien 3 is used in first intention, but we are still using the self-expanding core valve in selected cases, especially in small annulus or very large annulus, or when we have very heavy calcification or extension of calcifications to outflow tract. But the leading device that we are using in our department is the balloon expandable valve. So why do we prefer using a balloon expandable valve in 2021? The potential advantage are the physical properties, the hemodynamic properties, the clinical features and easiness of use, and the clinical results. So in '94, when I was thinking about developing a transcatheter aortic valve, which were the basic requirements? We needed a valve with a high radial force required to push aside the valvular calcification. And this was supposed to offer a circular opening of the stent for the purpose of hemodynamics and durability of the valve. We also needed to protect the adjoining structures like coronary ostia, mitral valve, and his bundle. Actually, the transcatheter valve was supposed to compare favorably with the surgical bioprosthesis. And we have some additional criteria like the hemodynamics and durability, comparable again to the surgical bioprosthesis. The easiness of use, which was very important, and the safety of use, offering a predictable implantation. And also this valve had to be adapted to a majority of patients concerning the access and the sizes. And I have the feeling that the balloon expandable valve met all these criteria. So first of all, we validated the concept of valvular balloon expandable stenting in AS by a landmark autopsy study, if you remember. And I was observing that during balloon aortic valvuloplasty, high pressure balloon can fully expand all calcified valves. So the same expansion was expected to be obtained with highly resistant stent frame. And we could confirm that, by this autopsy study showing that in spite of heavily calcified valve, the balloon expandable valve was absolutely offer the possibility of getting a circular opening of the valve, pushing aside the calcium, whatever the amount of calcium. And also, I could demonstrate that considering the sizes of 14 to 16 millimeter in height, with a diameter of 23 millimeter, we were out of the coronary ostia, the EV septum, with the his bundle and the mitral valve. So this was the confirmation of the concept of valvular stenting. These are my drawings, and this is what we got from our startup, the PVT valve, the percutaneous valve technology valve, which was finally a 3-leaflet valve, polymer, then equine pericardium, with a stainless steel stent and 30% coverage outside of the stent to avoid the regurgitation of blood into the left ventricle. And this model of valve was used in the first-in-man case, but also in the next 100 patients before Edwards acquired PVT. So the lessons for the first case was, first of all, that the feasibility of TAVI was confirmed, that we could obtain an accurate valve positioning. There was no migration of the prosthesis, no coronary occlusion, no mitral regurgitation, no need for pacemaker. There was a grade 1 AR in the first patient, optimal valve function, and optimal valve hemodynamics. So this was very encouraging, and this confirmed our autopsy finding. So the potential advantage of the balloon expandable valve that we conceived was that there was a subcoronary position offering a free access to left main and RCA on long term, no mitral regurgitation on short and long term, and pacemaker required in only less than 10% of patients with this first model of balloon expandable valve. So I was very, very satisfied. And you can see here the first demonstration of easy reaccess to coronary artery after using a balloon expandable valve. And this is something that you couldn't see so clearly, or at least obtain so easily with a self-expanding valve, as you know very well. So this is 4 years after implantation of the balloon expandable valve. So you have here on the screen the evolution of the Edwards balloon expandable valve after the acquisition of the percutaneous valve technology by Edwards Life Sciences. You can see the improvement of the technology with a number of available valve sizes, the sheath compatibility decreasing to 14-16 French with the Sapien 3. So this was going in the right direction. The balloon expandable hemodynamics compare favorably to the surgical bioprosthesis. This has been absolutely demonstrated at the very beginning of the experience in 2009, showing the gradient at discharge and the mean valve area offered by the balloon expandable valve in comparison to the surgical standard valve and the surgical stemless valve. So we got our objective concerning the hemodynamic. The physical properties, using a highly resistant stainless steel, then a cobalt chrome frame with the last generation of balloon expandable valve, we got a circular frame expansion in 95% of the cases. So this was also something that we were looking for. And we used in this valve the treated bovine pericardial valve, which is thicker than the porcine pericardial valve used by on the self-expanding device. We had a leaflet matching process. And the whole thing, as I said, offered a free access to coronary ostia, which was an important advantage in the younger population. Also, the technical advantages of the balloon expandable valve, and I am saying this because this is absolutely reproducible with the Myval. The easy and fast positioning, the high hyper-steerable delivery system, offering a crossing of the aortic valve coaxial, easiness of use, positioning, and delivery, and ultra-low profile introducer, which was 14 and 16 French according to the size of the Sapien 3. And as you will understand after the presentation of Francesco Bedogni, 14 French only with the Myval. So multiple size also available from 20 to 29, covering the clinical need. So the physical properties of the balloon expandable valve are similar to Carpentier-Edwards surgical bioprosthesis. The circularity, the leaflet matching, the bovine pericardial tissue anti-calcification technology, major advantages for long-term durability. The impact of scientific evidences were absolutely drastic, and you all heard about all the registries done with this balloon expandable valve, and the three landmark randomized trial in inoperable and high-risk patients, intermediate-risk patients, low-risk patients above the age of 65, very favorably, comparing favorably to the surgery. And in August 16, the apotheosis of TAVI, the FDA-approved TAVI in low-risk patients above the age of 65 years, the last risk category approved by FDA with a Sapien 3 and a Medtronic Evolute. And we had all these advantages of the balloon expandable valve, less AF, less death, stroke at 30 days, same pacemaker rate, faster recovery, but lower mortality, stroke, and hospitalization at 1 year, the main endpoint. And on the Medtronic side, similar death, disabling stroke at 2 years, better safety recovery at 30 days, fewer strokes, less hospitalization, but a higher rate of pacemaker and higher rate of PDL. So we are just expecting today the recommendation of the European Society. So here, these are the valves that have been developed over time, and as you know, very few did survive. And we have in Europe mainly the Accurate and Portico, some other kind of self-expanding valve. The Lotus Sage has been removed from the market, and we have today a new device, which is a upcoming outsider, the Myval from Marin, India, which is a balloon expandable valve, the only balloon expandable valve which is concurrent with the Sapien 3, and I look forward for that. So summary and conclusion. In 2021, all the characteristics of the balloon expandable valve does correspond to my initial wishes. A prosthesis with all characteristics of the surgical bioprosthesis, the position, treated bovine pericardium, circular frame opening, protection of adjoining structures, excellent long-lasting hemodynamic results, low rate of major complications, free onlay technique, predictable implantation adapted to the vast majority of patients, compatible with transfemoral minimalist approach in more than 90% of the cases, many advantages that should soon make bright the future of any other expandable valve, like, for example, I'll tell you the name, the Myval from Merrill, which is a fantastic device. I don't want to say what I think about it right now because Francesco will present the device and will give you all the characteristics. But I am a strong believer on the future of the Myval device. Thank you very much.
Oh, thank you very much, Alain. It was a great presentation.
Well, it was a quick one.
No, it was quick, but we could make a journal for the last 20 years. It was absolutely great. Thank you so much. Maybe we have one or two questions. Aníbal is from Rosario, Argentina. Could you make some very short comments? We're a little bit late in the program.
Yeah, for sure, Fausto, thank you. And I would like to thank Professor Cribier for sharing with us this amazing 20 years journey of TAVI that he has pioneered. Just a short question and a short comment before. You know that you mentioned that there are different commercialization strategies, and at least in Argentina, the self-expandable devices have the greatest penetration. By the way, could you make any comment about the re-access to coronary arteries and the advantages of the balloon expandable devices over self-expandable devices, as long as we move to younger patient and lower risk patient populations that will surely need new coronary procedures in the future?
You know, reaccessing the coronary artery is major aspect of the balloon of TAVI is extremely important, especially because we are now dealing with younger population. So I definitely think, and I think everyone will agree on the fact that it's easier to reaccess the coronary arteries after the use of a balloon expandable valve than after the use of a stent of a self-expanding valve, even though it can be done, but it's not a piece of cake, and so sometimes you can really fail, and so this is not acceptable when we are talking about the long-term durability of the valve and the need for accessing the coronary arteries in the future.
Okay, thank you.
And would you make some short comments? What are the main limitations of a balloon expandable procedure?
Yes, well, at the present time, the risk of rupture of the annulus, in case of massive calcification or when you have some protruding calcifications on the outflow tract, for example, this is one of the biggest limitations, and this is the reason for which we are using the self-expanding valve in this situation. And also the size, and especially the small size of the valve when it's below 21 millimeter in diameter, for example, because the self-expanding offers supra insertion above the level of the annulus. And so the gradient is remarkably lower after using the self-expanding than the balloon expandable valve. So I think the size of the annulus or the size of the valve-in-valve procedures, the surgical valve is very important and have to be taken into consideration when you select the valve. And the core valve is better in small size annulus, there is no question about it.
Good. You answer. What is your indication for self-expandable? You just answered before I asked. Great.
Yes.
Thank you, Alain. Maybe we should move forward to the next presentation. Is Marco? Would you like to present the next one?
Professor Fausto, while Francesco is putting his presentation, we will show a little a video from João Cavalcante from the Minneapolis Heart Institute. Pedro, pode colocar, por favor?
Hello everyone, I'm João Cavalcante from Minneapolis Heart Institute, and it's a pleasure to have the opportunity to invite you all for the upcoming second TMVR workshop that we'll have here in Minneapolis, and obviously virtual to the world, on May 7th and 8th. This is the second version of the very successful last year October course that will be also done online, in which we will discuss in depth all the procedural aspects of CT planning and understanding as well the nuances of patient selection, device preparation, and obviously anticipating potential complications and remediations. As you all know, this is a rapidly evolving field, and we have the privilege to have key opinion leaders here from Minneapolis Heart Institute, Dr. Paul Saraja, who leads our structural interventional group, Dr. Vinny Bapat, who is our chief of CT surgery, as well as a special guest from the Mayo Clinic, Dr. Mayra Guerrero, who has published extensively in this field, especially in the conundrum of the mitral annular calcification. The link for the registration is down below, and you will be able to do this from your home and joining also the sharing of the slides and all the content. Again, I would like to thank Gustavo and the 4 Valves for all the success that his group has had and for the support of our initiative. I look forward to seeing you soon. There are only, I think, 5-6 seats left, so please go for and register yourself. I look forward to seeing you all. Thank you.
Come back.
Thank you, Gustavo. We have changed the presentation, and now the presentation will be by Mr. Sanji. He will present about next generation balloon expandable TAVI, science and clinical updates on Myval THV. Please, Mr. Sanji, can you share your screen with us, please? Okay, great. We can see your screen. Perfect.
Sorry.
Okay, great. Okay,
so I'm going to
we can hear you.
And I'm going to present once again. Sorry, we've all got so used to the Zoom that this system takes a little while to get used to. But thank you so much, everyone, for joining in. And my name is Sanjeev Bhatt. I've had the honor and the pleasure to be the part of the development team for the Myval transcatheter heart valve system. And Professor Cribier, the sequence couldn't have been better. This was, in fact, the right way to begin. My humble thanks to all our teachers, and there are so many of y'all over here. I cannot thank you enough. Also, a big thanks to our esteemed partners in clinical research and to the entire Brazilian interventional cardiology community, especially the tower enthusiasts who have gathered this evening or this morning, actually, in Brazil. So this is where we actually picked up where we essentially tried to analyze the unmet clinical needs still in the TAVI segment. And we said, if we have to develop the next generation balloon expandable valve, how should it look? So the key focus has been essentially, as Professor Cribier mentioned before, on the valve design, the delivery system itself and the introducer sheath, the ability to get all the valves from 20 till 32 millimeters diameter across a 14 French introducer sheath would make up a very strong clinical argument. And in response, we were able to develop the Myval, and this is exactly how the device appears.
Sorry to interrupt, but if you can make it full screen.
Yeah, it is. Can you now see my full screen?
We can see your full screen, but can you put in presentation mode, because it's not in presentation mode. It's better to see in presentation mode your PowerPoint.
Actually,
just the PowerPoint.
Yeah. Yes.
Yeah, this one.
I'm doing just that. Yes. Is that now in the full PPT mode?
No.
Not yet.
So sorry.
Not yet.
Yeah. Okay. So pardon me this little slack.
Okay, no problem.
I'm doing exactly what is. Just give me 1 second more. I'll try. Is it now in a full screen?
Yes,
yes, right now.
Thank you so much. So this is exactly how the Myval design actually appears. So as you can see, this is a nickel cobalt alloy frame. We use MP35N essentially for the high radial force and the radio opacity. The MP35N alloy also spontaneously renders the design MR compatible, which may be required in certain cases. To focus on the heart of the design itself, I'd like to point out, if you see, the entire design is based only on hexagons. There are no other elements which incorporate the frame of Myval. The aortic end are purposefully the large open cell hexagons, which allow us to keep the coronary ostia open, while supporting right below them are two rows of smaller hexagons. And very interestingly, if you notice a little closer, you will realize that these are not regular hexagons, which means all the 6 sides of the hexagonal frame are not the same length. And this has an impact at the lower half towards the ventricular end in order to bring in higher radial force. So we actually call this the hybrid honeycomb because all the cells are hexagon, but the upper half, the aortic end, are open cells, whereas the lower half is the closed cell stacked on one above the other for high radial force. The frame classically splits unequally, so 47% towards the closed end and 53% towards the open end. And this also has a little bit of more leeway when it comes to low-rise coronary ostia. From 20 millimeter till 32, the frame height is a little shorter, so it renders about 17 to 21 millimeter. The valve is crafted out of bovine pericardium leaflet, and we are sourcing this from a very reputed group back in Australia. Back in Vapi, we undertake the tissue with a special anti-calcification treatment, which is proprietary to the company. Now, speaking a little bit about the ventricular end or the inflow zone, Professor Cribier mentioned this as a part of one of the initial thought process that the valve frame must be covered. And we've done essentially that. The internal part of the frame is covered using polyethylene terephthalate. This is a non-hygroscopic woven plastic. It essentially allows us to protect the tissue within from any inadvertent calcium spicule from damaging the tissue below. While the external frame is loosely stitched in form of a larger skirt, and this helps us plug microchannels and further reduce paravalvular leak. The size matrix itself is exceptionally unique, and this is what makes up for a very strong argument in when we are selecting the sizing for TAVI. So the conventional sizes of 20, 23, 26, and 29 are available, but in addition, we have the 21.5, the 24.5, and the 27.5. So the intermediate size matrix are something which is a new addition, and in addition to these sizes, we also have the extra large. So we have the 30.5 and the 32 millimeter extra large sizes. As we speak, the valve is approved in India. It is in fact approved in more than 40, 50 countries globally, including in Brazil. And so far, about more than 2,400 Myvals have been deployed globally in regular clinical practice. Some of the reasons why we saw this, the early success of clinical success of Myval in most of the cases has been attributed to the design itself. And I'm going to just spend a moment here to articulate exactly how the design renders very nicely across the aortic root when we do the TAVI. So here is a cartoon of the aortic end of the valve frame, large hexagons, which are open cell in configuration, and supported right below are the ventricular cells, which are closed cells and tightly packed, which account for the high radial force. The vertical picture is that of the Navigator balloon. Now, I should say here that we recommend that the valve should be crimped directly over the Navigator balloon in the cath lab prior to insertion within the sheath. The Navigator balloon distal end looks something like this. Internally placed are 3 large prominent radiopaque markers, the proximal, mid, and the distal. The central marker being the geometric mean of the balloon. Now, internally placed are counter-opposing 2 stoppers, a proximal and a distal stopper. On hydrating the valve, these stoppers actually create a very interesting central shallow zone. And we are directly crimping the valve on this central shallow zone. Now, here is what happens as we crimp the valve. So the V-shaped struts on the expanded frame on the Myval, upon crimping, they come and nest close to each other. This nesting has a propensity to create a dark band, which is nicely seen in the fluoroscopy. The vertical struts of the valve frame actually render as a lighter band, and this sequence is simply repeated because the entire frame is only hexagon. So you see this very interesting sequence of alternating dark and light bands right from the distal to the proximal zone. So this zebra crossing kind of a pattern is what we use for positioning of the valve and to eventually deploy it across the orthotopic position. So I've borrowed this this CT three-dimensional image with all the three cusps separated and in the straight line for us to have the correct operator's viewpoint on the annular plane. And as we get the Navigator system, you can see as seen in this cartoon, you can very easily identify the dark and light band sequence. And the idea here is to use the middle of the second dark band as the landing zone. And I'm going to repeat this. So the landing middle of the second dark band from the ventricular end, which basically allows us to keep 70% of the valve towards the aorta and marginally so towards the ventricle. Now, keeping the valve in this position, as we expand the valve under pacing, we will see that the valve has a tendency to foreshorten in a unique manner, allowing only a marginal portion of the valve to be subannular. And the infraannular depth of the valve is usually in the range of 3 or 3.5 millimeter. I borrowed one case from Professor Luigi Saleme, south of Italy in Montevergine. And this was a patient presented, an elderly male, 84-year-old with severe aortic stenosis. And this is the baseline aortic root angiogram. As we can see, it's heavily calcified aortic root. They decided to do a pre-dilatation using a mammoth 20-millimeter balloon. And as we continue to get the valve across the aortic annulus, we see this characteristic separation of the dark light band with the pigtail remaining at the base of the non-coronary cusp. As we continue to expand the valve, we will see this nice dog boning valve, which is also very intentional, allows us to stabilize the valve under expansion. And as you continue to inflate the Navigator balloon, you see this very typical foreshortening, which is less prominent from the ventricular end and more so from the aortic. The end result is something like this. And this has been the characteristic deployment of the Myval. Usually we'll end up with well-preserved coronaries, absence of any clinically significant paravalvular or central AR, restored hemodynamics and low gradients. Very interestingly, most of the cases have been associated with low rates of new permanent pacemaker. In this case, they had used a 26 millimeter Myval in diameter. The entire size matrix evolved over the last as many years is something like this. So from 20 till 29 millimeter, all valves are compatible till 14. But in addition, we also have the XL size, which are also 14 French Python compatible. So this makes up for a very interesting situation. Very importantly, every valve diameter is a unique diameter. So the idea is, as we choose the valve diameter, which is better approximated to the aortic root annulus, keeping in mind the aortic root geometry and the morphology and the spread of calcium, we have a much better chance of sizing the valve as per the anatomy and not to change the shape of the valve to suit the anatomy. So this is one of the important facts that I wanted to draw your attention. Over the last 1 year, as we've done more and more of cases, and there are many seniors in this room, Professor Bedogni is going to speak a lot about his experience. In fact, one of the largest across European Union. We see the intermediate sizes are almost half of the valves used. So this establishes the need for a larger size matrix, which is reflected here in my valve. Some of the early cases of the 32 millimeter extra large. This is one of the first cases done by Professor Ferrell Hellig in Johannesburg, South Africa. This was a younger male, 67-year-old. And the Myval deployment is very characteristically the same as I described before. Another case that I would have to, I have on my screen is, this is a second case, which was a valve-in, valve, where a Myval was nicely 32 millimeter Myval was deployed across two previously deployed Evolute R with excellent gradients at the post-procedural level. A little bit about the Navigator system. The Navigator system is the balloon delivery system for Myval, dedicated. And as I said before, we trim the valve to insertion into the sheath. Stoppers, the distal and the proximal, the valve sits nicely snug before it is entered into the sheath. So unlike the previous generation technology, there is no need to maneuver the valve while you are in the aorta. The Navigator system has the ability to do a high degree of flexion. So as you are at the thoracic part in aorta, the idea here is to flex the wheel on the proximal handle. This allows you to bring the guide wire system to the inner edge of the arch, thereby minimizing the propensity to scratch across the contralateral wall. The system is extremely flexible, and I borrowed this case from Professor Darius Jegelek. This case was not the usual Monday morning case that you'd like in the cath lab, excessive tortuosity of the aorta, and we had to use double Lundquist in order to get the valve across this tortuosity. This was a type 1 bicuspid, an elderly male, and a 29 millimeter was very nicely deployed across the horizontal aorta. Moving on a little bit on the Python introducer sheath. This is a 14 French introducer sheath, 30 centimeter usable length, extremely lubricious, so you don't need to screw the sheath inside, just a little push in and it will glide through. The distal end is radio opaque and it comes with a 14 French dilator. The proximal port has got 3 hemostatic valves which allow us to prevent any back bleeds. The sheath has been used in variety of clinical setting, most commonly the transfemoral, but in case you have a hostile iliofemoral tract, then the sheath can be conveniently used in alternative access. One of the key points of the sheath which made the Python a little more in favor across the cases is, in case you're not able to cross the aortic root, then you might have to pull the entire system out. With the Python, this is very conveniently possible. And here is a case where, because of the difficult aortic root or a bicuspid or a very narrow defective orifice area, you might have to take that decision. You do what you have to do and then again go back and deploy the valve. So very convenient system with Python. We also have an interesting accessory called the Mammoth balloon. This is an over-the-wire system, very versatile, and comes in diameters of 14 till 25. The idea here is to not cause any iatrogenic damage while doing a pre-dilatation, just to have a little orifice area. More is going to be spoken by seniors in this group, so I'll not spend too much time on the global clinical program, but we started off with the Myval 1 study here in India, and then the entire clinical forum has now really taken up a very good shape. So we have Professor Philip Freeman and Professor Serruys, along with Professor Bedogni, who are going to speak more on the landmark and the compare TAVI. But as a company, we are fully dedicated to furthering clinical research in Myval. The one-year data for the Myval 1 is very comparable. Some of the key points that I'd like to draw your attention is the low rates of new permanent pacemaker, which is fairly reflective of the clinical practice. The landmark study has begun enrollment, and I'm not going to spend too much time because Professor Serruys will speak more about this study. It's a prospective randomized study, 1:1 compared between Myval and the contemporary valves like Sapien and Evolute. The idea is to follow up these patients up to 10 years with primary endpoints at 30 days and subsequently at 1 year. The compare TAVI is also going to be spoken by Dr. Freeman, and this study has also begun enrollment. And we are very excited to see how the study pans out in order to establish the clinical safety. So in conclusion, 2,400 valves done so far. Generally, the Myval has been perceived as the technology which is next generation with the ability to precisely place the valve and deploy it with accuracy. The ability to have intermediate and extra large sizes are very interesting. The valve does not have to be maneuvered within the aorta. It is directly clamped on the balloon. And the 14 French introducer sheath is extremely interesting. You can retrieve the valve in a situation you may need. So far, Myval seems to be associated with low rates of paravalvular leaks or new permanent pacemakers. Vascular complications are lower, and the tower-associated any adverse events have been noted lower in routine clinical practice. Like this forum, Merrill is sincerely committed to furthering clinical research and tower education, and the landmark and compare TAVI will establish the long-term efficacy of Myval in clinical practice. I thank you all for your attention, and thank you for attending this meeting. Thank you.
Thank you very much, Sanjeev. This was an excellent review for the novel technology. And let me just make a short question to Professor Cribier. We need to take the opportunity to have the pioneer here with us. Alain, you saw this is the intermediate sizing, and you also said after your presentation, one of the major limitations of the balloon expandable is the aortic rupture. Do you think this intermediate sizing could help or even could avoid this terrible complication?
Well, I see two advantages. First of all, certainly it can avoid these complications, so it should have a major impact in clinical practice, to select the right size for the right patient, and without the need for redilatation, for example, which is also associated with more stroke and more complications. So I think that obtaining the right size for the right patient is something extraordinarily positive, and I must say that I was very impressed to see that. Also, I would like to stress on the fact that we have the extra large sizes with the Myval, which is not available with either with the balloon expandable or self-expanding valve, which is extraordinarily useful. So I think all of the characteristics of Myval, I must say that I am very, very impressed.
Okay, thank you. So we need to move on. Now we have another very good expert. That's Professor Francesco Bedogni from Italy. Welcome, Francesco, to be with us. And your talk is going to be about Myval system, about the technical characteristics, unique differentiation features leading to procedure and clinical success. Francesco, please.
Thank you so much. I will try to share my screen now. My screen, I can see my screen now.
It's coming.
Because before we had, okay. So probably you can see now my screen in presentation. So thank you for the invitation. It's a great pleasure to be, and it's a great honor to speak after Alain Cribier for my presentation. So I hide the majority of my slides, of the technical slides. This is by conflict of interest, just to know that we collaborate for all the TAVI companies, so that I'm not only working with Mary. But anyway, Myval has some special features that they are very interesting. So this is the normal size, as the Sapien 3 sizes, but as you have seen, there is some intermediate size, especially some large size. And then I think this is very interesting for this new device. The other difference between Sapien 3 and Myval is the height. Except for the 20 millimeters, Myval is a little bit shorter than Sapien. This is maybe helpful in when we have low coronary access, and we gain some millimeter to reduce the interaction with the membranous septum and to reduce the rate of AV block. Other characteristic, as you have already seen, is the Python sheet. Now is improving the membrane of the sheet. Now it's a very interesting sheet that helps us and allow us to recapture the valve if we can't implant. Yeah.
Your presentation is not in the presentation mode at PowerPoint. Can you put your in presentation mode, please?
I'm in presentation.
For instance,
now I'm in presentation. You can see the presentation anyway.
Yes, but not in the presentation mode. We can see all the slides, your screen, but not in the presentation mode.
Right, because I see my computer in presentation mode. So why? I come back to the presentation. You can see the presentation now.
Not yet.
No, not yet, but now I'm in presentation mode. I see in presentation. Now I see in presentation mode. Okay. I stop the presentation. I stop the presentation. Okay. Yeah. Full screen. Full screen. Full screen. I can. Just a moment. Huh? Oh, we have now full screen. I saw you in the full screen. Just a moment, huh? Let's see. Having full screen now, but I can't share. I don't know why. Or maybe. Okay. Yeah.
Okay.
Yeah. You can see in full screen now?
Yes, perfect. Perfect right now. Thank you.
I'm sorry for that. So this is a very interesting sheet that, yes, is very... Yes. So the most important thing that you have to remember when you use this kind of sheet is that you have to delete before, because to avoid friction of the valve during the insertion. So it's very important to delete the sheet with the 18 delator after the insertion of the sheet. This is a characteristic. Now, coming to our experience, I'm in San Donato Hospital since July 2015. And until February, we perform around 1,300 TAVI. And as you can see, we use a lot of different devices, but 8% of our experience is with the Myval. We use the first Myval. The rate of Myval is increased to 22%. So now we have the experience of more than 100 Myval when we perform the majority of TAVI, but even for valve and valve. So this is our series of patients. This is a normal patient for TAVI, intermediate risk patient with severe aortic stenosis, and the majority of the access, not 96%, the large majority was a femoral access. We perform a one transcaval access, that is, we can perform with this valve, and two subclavian access. So it's possible to implant this valve even through transcaval and subclavian access. The interesting thing is that we use the half of cases performed in our centers performed with intermediate size valve. So we use a lot of intermediate size. So because it's, I think it's interesting to have the possibility to have a precise sizing with our valve. This is the results, 99% of procedural success, only 3% of pacemaker implantation, one left band bunch block, 7% of vascular complications, minor vascular complication, and one case with death for the need of second valve patient with an embolization. The rate of more than mild PVL is very low, 2%. So we are very, it's a very interesting result. It is our first experience with this valve. We see now some special indication where we think that Myval is a particular indication for some patients. This is the problem that Alain told before, is the problem of large aortic annulus, where it's very difficult sometimes to have accurate, adequate anchoring, and the risk of PVL is very high. This is, for example, a valve with a perimeter of 103 millimeters and an area of 828 millimeters square. You see that the resulting literature of the TAVI procedure in very large annulus, are worse than in the common situation, because we have 10% of device failure with Evolut 34, and we have 4.2% of device failure with Sapien 3. It is not, it's not so rare situation. This is a series of patients, the survey that done by Dr. Alzheimer, that is publishing a multi-center registry with large Myvals, and you will see that the distribution of annular area more than 650 millimeters square, that is the limit for Sapien 3. And is quite high. It is 3.5% of all patients, and 1.7% of patients are out of all kind of device, or are off limit. And even if we inflate the Sapien 3 29 plus 4 millimeters, we can join at maximum the size of 742 millimeters square. That is not, for example, enough to treat this kind of patient that we have to treat. This is a patient, the patient that we have seen before, with an area of 800, more than 800 millimeters square, where the Myval 32 may work. This is the implantation. You will see the very, very large annulus. As you have seen, the implantation is quite easy because they are the dark band to be placed in the right place. The inflation, we need a quite strong physician. We have to inflate very, very well. This is the result after the nominal lumen. The valve is well fixed, but it is a very tiny perivalvular leak that we can perform with the same balloon, the post dilatation of 5 cc more, with 5 cc more, and you can achieve a perfect result. This is our experience at the moment. We have the 32 millimeters and 30.5 millimeters available since 6 months ago. So now until now we perform 6 cases, and we have performed a 7th case anyway. It works very well. You can see some very large areas, and we can achieve a very good success, 100% of device success, no major complication, only one minor vascular complication. and zero pacemaker, and a very good final result, no PVR. For the intermediate size, why might be helpful the intermediate size? I will show just an example where I think that's very interesting to have an intermediate size. This is a very young man in Cook, gear-driven activectome that in 2005 a complete root replacement in the Toronto root and with coronary reimplant. This is a stentless valve. Then we have the immediate for RCI occlusion, a bypass. But from 2005 and 2019, he had the progressive bioprosthetic dysfunction with moderate aortic stenosis and severe aortic regurgitation. This is the situation of this patient. You will see the Toronto root is completely calcified. It's a huge calcification. The age of the coronary age is quite acceptable, but anyway, the problem is the complete calcification. This patient asked to perform, we discussed with the surgeon what to do. The surgeon told us, if the patient wants to start to work immediately, you can eventually put a TAVI, and then we will see in the future what to do. But we discussed from them, our team at the end, we decided to perform TAVI in this kind of patient. This is the angio you will see, and this is a severe aortic regurgitation and a calcified aortic root. At this point, we check in the app for valve-in-valve choose, and what to choose as a TAVI device, and the app showed us 26 or 29 sapien 3, but the patient had aortic regurgitation that tends to oversize a little bit the device, but he had a huge calcification that tends to reduce the oversize. So at the end, you choose intermediate size, in this case 27.5, Myval device. With this is the implantation. With is a stentless valve, so we decided to protect the left coronary artery because it's a little bit lower. But you will see that we could have a perfect result, leaving the coronary free and achieving a perfect result with the intermediate. At the end, I can tell you that you can perform very well. Use the Myval even in my mitral bioprosthesis failure. This is a BioCore-31. We perform 3 cases of valve-in-valve with Myval with a very, very good result, as you can achieve exactly with the sapien 3. So, and this is the final result. Okay, and this is our experience, and I thank you for your attention.
So, thank you very much. It was a great presentation showing your great experience with Myval. Marcio, do you have any questions? We are running a little bit late in the program.
I would have.
Professor, your mic is off, Professor Cribier. You have to open your microphone.
Yes, Francesco.
Okay, great. Right now.
Again, you have a tremendous experience with Myval, and everyone here can be very impressed by your experience. I just have a question concerning the easiness of use. Would you, in all cases, be able to go through a 14 Frenchies, even using extra large size of the Myval, because this would be a big advantage in comparison to the other devices?
Absolutely, yes. There is no difference, no difficulties to use even 32 millimeter size with 14 French Python sheet. Absolutely.
That's really amazing. Fantastic. Yeah.
Okay, Fausto, I think that you can move on after this question of Professor Cribier. And I would like to invite Dr. Ignacio Santos from Spain to present Myval THV, Commisural alignment technique, and Matchball study from Valladolid, Spain. Welcome, Ignacio. Thank you for your time.
Thank you very much. Can you see my screen now?
Yes, great.
Okay, so you see my presentation is moving properly. Yes?
Yes.
Okay. Thank you very much for your kind invitation. I'm really honored to be amongst this great panel today. I have to discuss two aspects of Myval technology. First, commisural alignment, if we can do it and it makes sense to do it. And then I'm going to present a retrospective comparison with some balloon expandable devices in the Matchball study. So we already seen this slide. They discuss the structure of the valve, but we have not discussed this aspect, the commissures. See where the commissures are sutured. It's a dual strut, and I want to keep this in mind, all the audience. But when the valve is crimped, we are not so able to see where are the commissures. With some devices, what we tend to do is to manipulate the device, for example, with accurate nail in the ascending or descending aorta, to try to align the commissures. Here it is not possible to manipulate inside the patient for several reasons. First, we don't see clearly where the commissures are. Second, the system is very flexible, which is good to avoid damage to the aorta. But of course, if you try to rotate the system inside the patient, there is now a predictive movement of the delivery system. And finally, the sheath is a 14-frame sheath, which is very good to reduce the risk of vascular damage as well. But the valve is quite tight inside, which means that trying to transmit a rotation inside the patient is not feasible, is not predictable. Then I want to discuss if there is a role for commisural alignment with one patient. This is a 75-year-old male with several risk factors and importantly with a prior coronary disease. So this is a young patient and likely the valve will degenerate along the year. So there is a possibility of need for valve-in-valve in the future. And also there is coronary disease, which means that in the future we might need to re-intervene the coronary arteries. We selected a 27.5 valve for this patient, and we see that the vascular access was quite good. And now I want to focus the attention on this aspect. When we have implanted the valve, we can see clearly where are the commissures, the neo-commissures, because we see clearly this dual strut, but not when the valve is crimped. So can we predict where is the commissure, the neo-commissure ended in our patient? We have developed a script to predict this. If we advance the delivery system and we know how we have crimped one of the commissures, for example, pointing up at 12 o'clock, and we determine the aortic center line, we know where that commissure is going to end up in our patient. And if we know that and we don't like how it ends, we can predict how many degrees we will need to rotate the valve before entering into the sheath to achieve this appropriate commissural alignment of the native commissures and the neo-commissures. In this video, I want to show how we can do it with Freeman, because we are collaborating with them to develop this tool and make it feasible with any device. First, we need to have the long aorta, the center line of the aorta to the descending aorta, so to the end or even to the femoral. Then we need to mark at 12 o'clock the descending aorta, so that we can determine if one of the commissures is pointing up, is pointing at 12 o'clock. In the descending aorta, the commissure is going to be placed there. So this is our marker at 12 o'clock. See the vertebra here. We simulate a valve, just the commissures. And we have crimped, if we have crimped the valve at 12 o'clock, then this should be like that, okay, when we are in the patient. These are the commissures crimping the valve at 12 o'clock. Then we advance this valve, setting the offset at 0 millimeter. We advance in this position to the outer loop, and we see that there is a commisural misalignment completely. So we see how many degrees we would need to rotate the valve. And we would need 50 degrees of rotation counterclockwise. Okay? Then how do we do that? With the crimper of the Myval, we just measure with this device that we have 3D printed the number of degrees, and we just need to rotate the valve before crimping it, pointing one of the commissures 50 degrees, like here, okay? And then we crimp. In the patient that we were discussing, we printed the aortic root, all the aorta, and we performed the implantation. After that, we cut the aorta, and we checked the commisural axis and the commisural alignment, and you can see that in the simulation, it was perfect. This is crucial because if in the future we are going to do a valve-in-valve procedure and the coronaries are low, we can do basilica, of course, but basilica only makes sense if we have the coronary just in front of the leaflet. If not, you will occlude the same way the coronary if you do the second valve implantation. So then let's go to the valve implantation. As you can see, we advanced the delivery system in the recommended position, but we have already crimped our valve in the adequate positioning. We have some very nice cases presented by Dr. Bedogni. So this is one of more nice and easy implantation of the device. And afterwards, we just check the result doing a CT, but also we can use the fusion with the Hard Navigator tool. If we do that, we can see the dual strut right here in the green peak. That is the native commissure. So we are perfectly aligned with the neocommissures and the commissures, the native commissures of our patient. We have done this in more than 10 cases now. We are going to report the result of this, but the predictability of this technique is very useful. And now, is it important in other terms? There are some publications suggesting that the gradients may be better when we achieve good commisural alignment in those valves that are intra-annular, like balloon expandable ones. It might also reduce the stress of the leaflet, so reducing the risk of degeneration. And it might also reduce the stagnation, the thrombogenicity around the valve. This is all to be proved in the future in real clinical practice, but it seems that there is potential advantages to be taken into consideration. And then I'm going to move to the second part of my presentation, the match comparison of the hemodynamics and early outcomes of SAPIEN 3 and Myval. These are all the authors of this manuscript that is actually under review now. We are answering the reviewers. We included patients from 8 European institutions, 1 from the Netherlands and 4 from Italy and Spain, respectively, that were treated with one of these valves in every one of the centers between 2018 and 2020. We recorded all baseline, procedural, and in-hospital results. Importantly, we gathered all the echo images that were centrally analyzed at baseline and 30-day follow-up. Our main endpoint was hemodynamic, so the regurgitation and the transvalvular gradients, but we also have some clinical outcomes to record. The study was not powered enough from a statistical point of view to detect difference in mortality, for example, but it was powered enough to detect differences in clinical efficacy and early safety according to Part 2 definitions. So regarding baseline differences, you can see that the groups are different, 286 with SAPIEN 3, 130 with Myval. For the hemodynamics, as I mentioned, we did a matching process taking into consideration the area of the aortic annulus, perimeter, eccentricity index, degree of calcification, left ventricular ejection fraction, and body surface area. So some differences in the baseline degrees and ejection fraction that were corrected after matching. And regarding the outcomes, this is very, very important. There are no differences in technical outcomes, but as you can see, there was 4 annular rupture with SAPIEN 3 and no cases with Myval. You discussed before the intermediate sizes and the importance for that, and 6 coronary obstruction with SAPIEN 3 and 0 cases with Myval in this cohort. Procedural success was comparable, and if we move to in-hospital outcomes, we can see that the rate of permanent pacemaker was half with Myval than with SAPIEN 3, and this was significant. This was also significant if we excluded patients with left bundle branch block. And now we are gathering the ECGs from all these patients to have a central ECG analysis and determine if this is just a hint of something bigger. Also, we have a higher rate of vascular complications with SAPIEN 3, but there was not matching for the vascular quality in this study, so I would not take this too much into consideration. There were no differences in hospital death, but at 30-day clinical efficacy was comparable and early safety was better with a Myval device. Regarding the outcomes, at baseline there were no differences between the two devices after matching, but you can see that at 30-day follow-up, the mean gradient and the aortic valve area were better for Myval, and indeed the rate of moderate and severe mismatch was significantly lower with Myval. And regarding aortic regurgitation in the match 120 pairs, there were no differences in our patients, with no cases of moderate or severe aortic regurgitation in patients treated with Myval at 30 days. Of course, we have to see the result of randomized trials. This is the most important. We are currently recruiting patients for the landmark trial under the leadership of Professor Serruys, and we will see the results of comparing Myval not only with SAPIEN 3 and Ultra, but also with Evolut R and Pro. So my main conclusions are that there are favorable clinical outcomes with Myval in terms of early safety. Also favorable hemodynamics with better gradients and similar regurgitation compared to SAPIEN 3. A hint of lower need for permanent pacemaker that was also mentioned by Professor Bedogni that we need to explore more in detail. And therefore Myval is the first alternative to the existing SAPIEN 3 balloon expandable device and compares favorably with it in our study. Thank you very much.
Thank you. Thank you, Ignacio. Thank you for your presentation. We have, I think that you have a time for one question. Luis, do you wanna make a question for Dr. Ignacio?
Yes, I would like to. Well, thank you for the invitation. I'd like to ask about the. Well, I found really amazing this crimping technique. Do you think is there any possible that we could perhaps do some landmarking on the device per self, if you can ask Mario to do it, because probably it would be, because I think I can understand the technique, but I don't know if it's so replicable on other centers, because it's quite complicated to do the crimping and all the measurement before. I think before you do the crimping. I don't know if you can talk about it.
So the idea is to make it easy, not something complex for the centers, which means that when you do your analysis in many centers with Dimensio, in others with other softwares, you measure your diameter, your aortic annulus area, and also you predict the implanting projection to have the three cusps aligned. So if you are also able to predict how many degrees you have to rotate the valve before you crimp, it's just one simple step in the previous analysis. Of course, if you have a marker in the delivery system, you can check before implanting if you have done it correctly. But if you haven't, then you have to remove everything, because you should not manipulate inside the patient, which is an extra step. And I think in most places they won't do it once the valve is inside the patient. So I don't find it so useful for the delivery. But I think all the technologies are incorporating something like that in their delivery system. I think this is the next step in TAVI technology. Of course, it will take a while to generalize it, but I think it will be easy and just one more step in the analysis at baseline.
Thank you.
Great. It's time to move on. It's my pleasure to ask Philip Freeman to make his presentation. It's a pleasure to have you here with us, Philip. And we're going to talk about case in-box presentation compare trial.
Yeah, case in a box. I will just start my presentation right now. Hopefully you can see my presentation now. Is that working okay?
Yes. It's coming.
Perfect. Yeah, I'm extremely honored to be invited to speak in the presence of such esteemed colleagues. My name is Freeman. I'm a cardiologist in Aalborg in Denmark. Actually trained in Britain and moved to Denmark almost 6 years ago. One of the 4 surgical centers in Denmark. We're not the biggest TAVI center in the world. We perform just 120 to 140 TAVIs per year. We have quite a complex caseload. We don't do very many non-femoral or non-vascular access TAVIs. We did just 1 transapical last year. And we do a lot of complex femoral iliac intervention, annular cracking, and TAVIs on LV support if necessary. There's our TAVI team. Particularly nice day when we managed to perform 5 TAVIs in one day when we had 2 subacute patients. And of course, none of these TAVIs will get done without a well-functioning TAVI team. We had the great honor of being invited by Alain Cribier to perform a live case just 2.5 weeks ago. And so I'm going to do a case in a box of that particular case with a mixture of angio pictures and some live pictures as well. The patient was 83 years old, a fairly standard patient in many ways, which I think is very useful for people to see. For those that haven't seen a Myval implantation, she had a peak gradient of 71, mean gradient of 40, and a preserved LV with a valve area of 0.6, moderate pulmonary hypertension with right ventricular function. She had atrial fibrillation, ischemic heart disease, diabetes, and she was on Xarelto treatment, which we paused 3 days before and bridged with aspirin. NYHA class 3 symptoms. She'd actually been admitted with angina, just with diffuse coronary disease, which we assumed was her severe aortic stenosis. Mild, moderate annular calcification, but nothing really dramatic at all. She had a common origin of her right brachiocephalic and left carotid. We look at that in quite detail because we use a sentinel in most of our patients. Mild to moderate iliac calcification, quite tortuous, but again, nothing too difficult. Annular area is 376. That landed square in a 23 millimeter Myval. And we can talk a little bit about the intermediate sizes later. Some quick angio shots just to show her somewhat diffuse coronary disease, but no focal stenosis. The CT showing at the annular plane a few calcium rocks, but nothing dramatic, a little bit more calcium in the outflow tract. And there's her common brachiocephalic and left carotid origin, which sometimes can be a little bit tricky with sentinel. We planned, of course, ultraside guided access, which is our routine, sentinel stroke protection, and proglyze together with a narrow Myval implantation for the live case. Very flashy opening to Rouen, TAVI workflow, as I said. And just to give you an idea of the angiogram, I'll shoot through this. A setup shot with the right coronary cusp in the middle, routine setup shot for TAVI. And a couple of pictures looking at the sentinel stroke implantation, sentinel protection device. You can see here the first umbrella has been implanted in the brachiocephalic. Next time round, I'm now pulling it up into that common origin and delivering the left carotid filter. Doesn't take too long once you get used to it, especially if you're a radial operator. This takes 4 or 5 minutes to do. It's very traumatic at all. And now just a little live picture. We go straight to the patient, to the interesting parts. This is the python sheath being implanted. and a little bit of a few pictures of my hands, and also a few fluoro pictures, so you can see how the sheath behaves.
And we'll just invite that to the screen now. I hope you can see that going in okay. It delivers very nicely. And there we are. We already have an ACT that's within range.
And I think that gives you an idea of the Python delivering in somewhat tortuous iliacs that have been straightened out, but it's really a very nice sheath. The early iterations of the sheath had some issues with a hydrostatic valve, which bled a little bit, but that has been ironed out completely now. The next picture or video sequence I want to show you is the delivery over the arch.
Maybe we should switch to the page now. So you see the delivery system, like you did in the lecture. It's very different to other balloon expandable delivery systems. We really like it. It's directly fruit onto the balloon, which is of course nice, so there's no preparation in the aorta. It's a very lively system. It's very flexible. It's very adaptable. It can flex a lot, although because it's so flexible, we really don't flex over the arch whatsoever. And it has a lot of pushability across the valve, even with direct implantations. Of course, when things are new, it's a little difficult to get used to, but after a few short paces, you really begin to appreciate the delivery system. So we're going to go ahead now and implant this valve. So you just keep, maybe you can see the sheath up here, would be great. That's it. Going to focus down here on our hands.
Can I ask you a question? Can you give the same ambulation to the delivery system that you obtain with the Edwards?
Yeah, it flexes if you need it to, but as I said, because the delivery system is so flexible, we often don't need to flex as we go over the arch, which is nice, even with a sentinel in place. Right. So we're going to just put it in the system and push it through. And it goes in very simply, very easily. Maybe switch the screen again. So we skipped his thumb. You see it there. Delivery system. Can you see the screen okay now? Yeah. Yes, sir. Just coming up through the sheath. You probably can't see the tip of the sheath, but it has a radial opaque marker. Do you have some resistance, or is it a little bit? But actually, with the bigger valve sizes, you're meant to pre-dilate the sheath, but with the 23, you don't need to. So you push about as much as you do with an Edwards system. And now we're just driving straight up. We are not flexing here at all. And you see how the system tracks the arch very nicely. I feel no resistance whatsoever.
So you do not need any angulation there?
No angulation whatsoever. And then we'll just focus down on the area of interest. This system drives the opposite way to our Phillips system, so I just reorientate myself. So it's a little bit like driving a Citroen car when you're used to English cars. So, and then we're just pushing straight across the valve, and then we've crossed the valve with no problem. We've gone all the way to the LV. This would work.
And I think that gives you a very nice idea of how easily the valve goes over the arch. In the very uncomplicated arches, we don't tend to flex too much, as sometimes it builds up some forces, as does the Edwards system inside as you're delivering the valve. Sorry about my terrible Citroen car joke. Can't resist it being an Englishman. But And now we switch to the angios. We had a little technical problem in the live case, which means we couldn't take a feed directly from the screen. But just to look at the valve positioning now, you can see the valve and the bands that we've been talking about earlier. And we're heading for the second dark band. This route was a little bit awkward in the way that the valve was sitting. And you can see it looks a little bit deep there, but because of the way I thought the valve would probably behave on implantation, I decided to implant there and adjust the valve position on the way out, which is very easy to do with the Merrill delivery system. I think we'll just skip over this live implantation. Live implantation.
Again, we weren't managed to share. We just checked our positioning because we just slipped around a little bit. Yeah. Looks like we're deeper. Yeah, that's what we did. Oh, sorry. Yeah. Nothing on? Okay. Okay, actually, I'm okay with that there. It looks a little deep, but I think it's going to come up and we'll adjust on the way. TT, nothing on, raise face. Can we put something on again? Sorry, that was my mistake. Facing ready, facing on. Facing on. Yeah. 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 Almost. So the valve was a little skewed, but
and you can see in that delivery, we make a very slow implantation and adjust the valve on the way out. That's what we do with the Edwards system as well. And the position is very nice. It's very predictable. You get used to it very easily. There's a little bit of foreshortening from both ends, more from the aortic end, and it's very, very predictable to know where it goes. You can have a look at the wire-in angio shot with a nice alignment of the valve, a little bit of wire-related regurgitation. And the wire-out shot looks very nice, nicely aligned. On the echo after this case, I don't have the echo pictures, but we had actually 0 aortic insufficiency, which is our, is what we come to expect. And just to finish the case, we always do an iliac angiogram just to see if there's been any trauma or any bleeding issues. And you can see here tortuous iliac, which look absolutely pristine after the valve implantation. That's my case in a box. What I also want to quickly talk about is a TAVI compare, which we had a slide on earlier. This is a Scandinavian-led trial, principally led by Christian Terkelsen. He's a professor in Aarhus and a good colleague. There are 3 centers in Denmark randomizing between Sapien 3 and Myval. We are around about 30% of the way through the randomization and recruitment. There'll be a total of just over 1,000 patients, and this is an investigator-led randomized controlled trial. We're very interested in having new centers coming along wherever they may be. There's only a few criteria that the centers need to implant around 75 TAVIs per year. But if you would like to get in contact with us, Christian is the man to be in contact with, and his details are just there. We're very excited about the trial and the data that it will generate. We think it will be very important. We think it will help to, for sure, it will help to evolve the arena of balloon expandable valves and the solid evidence behind them. That's my presentation. I'd welcome any questions if you have any. Thank you.
Thank you very much, Philip. It was great to see your case in the box and also the compare trial. Perhaps we have a short question from Aníbal Dalmont from Rosario, Argentina. Aníbal?
Thank you, Fausto. I have no questions. I think that the case in the box case was very teaching and very didactic, and so I just congratulate Philippe for your presentation.
Okay, great. And I'll ask Marcio to present the next speaker, please, Marcio.
Okay, Fausto, let's move on. I think that you can hear Paulo Prats, the next presentation about the question. I would like to invite Dr. Luis Nakayama from Brazil. He will present our first case here in Brazil in Instituto Dante Pazanese, nearly Brazilian experience with a novel TAVI technology. Luis, please, can you share your screen with us, please?
Okay, I'm sharing right now. Let me see if you're in. Can you see?
Not yet.
Not yet.
Luiz, quando você clicar em apresentar, ok.
Yes.
So.
Okay, great.
That's okay?
That's okay. Let's go.
Okay. So, well, good morning for everyone. First, I'd like to thanks for the invite. Well, it's an honor to be able to participate in such a prestigious event. It was up to me to speak about the early experience at Dentist Institute with the Myval. Okay. So, what will be our first impressions of the novel TAVI? This table here shows the summary of the first 8 cases that we performed at Dente. The first thing that we would like to talk about is the age of the patient. The median age was about 77, almost 78 in this 8 first case. It's not a very elderly population that we were treating at Dente. Most of the cases was performed in male patients, 75% precisely. And we have only one case performed in a bicuspid valve that we are going to talk about this case later. We did pre-dilatation in half of the cases. And another thing that has already heard in this event that caught my attention, it was the number of intermediate size that we have used at Dente. We can say that 3/4 or 75% exactly of our patients receive this intermediate size. So it seems to me that we are getting pretty used to this size, and it's quite a little bit more comfortable to select these intermediate devices and not to be so afraid of the under or the oversized situations that we are commonly see. We only did post-dilatation in 37.5% of the patients. Most of them we did with the same volume we use as the deployment. And also our team in Brazil, we tend to perform minimally procedures. We did the femoral plus radial approach in about 6.2% of the cases. We have procedure success in all of our 8 cases with no complications so far. And by the time that I have reviewed the numbers, there was no need for permanent pacemaker whatsoever. So now I'm going to show you the first case. It's a case of a bicuspid valve. On December 8th, Dr. Fausto performed at Dentist the first Myval implanted in our country, Brazil. This is a 80 years old female patient. She has a class 3 New York heart symptom, and she has a past history of diabetes and dyslipidemia. Her echo shows a severe aortic stenosis, And from the CT, we evaluated the vascular axis. The femoral axis was not challenged whatsoever. There was a little bit more of a calcium, but there was no troubling in this device and in this axis. From the heights of the coronary in the world was okay, and the evaluation of the area showed a perimeter of 73 millimeters and an area of 422. So for this area, 23 valve would be 1.56 undersized, and 26 valve would be 25% oversized. So we thought that so we chose the intermediate 24.5 Myval seems to be ideal for this case, as it was 11.6 oversized by the time we did the angel. As we performed the baseline audiogram, as you can appreciate on the left screen, and we did a pre-dilatation with a mammoth size balloon, 40, as we can appreciate on the right screen. The navigation of Myval and the high flexibility of the Navigator system ensures the right position of the valve coaxial to the aortic annulus plane. The deployment of Myval, as you can appreciate on the left screen, and the control angiogram here on the right screen. We did a post-dilation with the same delivery balloon, as we can appreciate the final result on the right screen, with no coronary occlusion, and minimal aortic regurgitation, and a very, very satisfying position of the valve. And I'd like to share with you another case that's a very, very defined situation that we have a couple weeks ago. So it's about a 76 years old, it's a male. He has started about a month before the hospital admission, reporting a progressive dyspnea. He has past history of hypertension is a former smoke. And the echo shows a severe left ventricle failure with an ejection fraction estimated in 21%. The EKG shows this fluid rhythm. And in the hospital, he developed a cardiogenic shock and had to be transferred immediately to the ICU care. And after a heart team reunion, we decided to go for TAVI in this patient. So I'm going to show the images from this procedure. This is the 7th case of our institution. So here, oops. So we did the pre-dilatation, and we use a 20.7 and 7.5 valve for this patient, as we can appreciate here on the right screen. The control angiogram shows no coronary occlusion whatsoever, another minimal aortic regurgitation, and a very, very satisfying position of the valve. But what draws our attention, the thing is the most interesting about this case is that we did evaluation, how the patient has evaluated, and the series of echo that we performed on this patient. As we can notice, ejection fraction, about a week after, 10 days before after the procedure, we have a increase in ejection fraction, and it was consistent with the following exams. So in this case, we were very, very pleased with this result and about the right timing of the intervention. And that was the 2 cases that I would like to talk about. And I really like to thank for my for my opportunity. Thanks for the shared our experience and hope to be on another event. Thank you.
Thank you, Dr. Luis. I'd like to invite Dr. Paulo Prates to ask a small question. Paulo, please tell us your impression as surgeon about this new device, and can you make any question to Dr. Luis, please?
Okay, so it's a pleasure to be here among our colleagues, and I'm feeling comfortable, and I'm very impressed with the results of this device, and I have no questions, just a small comment, and I want to congratulate Dr. Luis with these good results, and it's very excited to use this device, and so congratulations for the outstanding presentation. Congratulations to all the colleagues. Dr. Alain Cribier, it's a pleasure to participate with you. So I have no question, just this small comment, and thank you.
Thank you, Paulo, and thank you, Louis, for this very nice presentation. It's my real pleasure now to present Patrick Serruys, Professor Patrick Serruys. That is a legend in our field of cardiovascular disease, I would say that. I remember when I first met Patrick, that was in 1988, 33 years ago, in a symposium here in São Paulo, Brazil. And after that, we met many times, and always Patrick was a pioneer, like Alain. And with stent, bare metal stent, Bena stent trials, DES trials with Professor Souza, and we worked together many times, and he's always collaborating with us here in São Paulo, Brazil. And Patrick is a real friend. That's my pleasure and a privilege to have with you. And we have not seen each other for a long time since this pandemic and terrible period that we are living. But even now online, it's great to see you, Patrick.
Yeah, thank you very much, Fausto. I mean, it's a real pleasure to see all of you, but in particular, of course, you, Fausto, and you, Alain. I mean, it's, as you say, 33 years ago, I think during that visit, we implant a wall stent, if I remember well, just 1 year after Julio Palmas and Richard Schatz in '87. And it's also an extraordinary pleasure to see Alain, because he came to Rotterdam to help us to do the first balloon valvuloplasty in 1986. And then he came back in 2004 to do the first aortic valve replacement in Rotterdam. So it's really a quite emotional moment for me. As you could see, I'm now in Galway, in Ireland, very happy. You see the name of young fellows which are working with us. You see the name is not very Caucasian, but coming from Japan, China, and Egypt. And then we are very pleased to work here with Professor Gonuma and Professor Soliman, who are in charge of the core lab for imaging. Just a few words about the video densitometry. It's performed using a single aortogram with the video densitometric technique, 2-time density curve, one in red, which is in the reference area in the aorta, and one in yellow, which is in the outflow tract. And then the ratio between these 2-time density curves is translated in percentage of regurgitation. We see here the color-coded assessment of the video density, and you see at the bottom the 2 curve, and in this case, after call valve, yeah. Let's see that, because that's a problem that everybody has. Eh?
Yes.
Because it's not in the presentation mode for us.
Yeah. As the other speaker said, it is in presentation mode, but not in your case. So we're going to work on that.
Sorry, yes.
Second.
Everyone had the same problem.
Yes.
No, it's interesting. I hope that we'll master that with Yoshi.
Yeah.
How does it look now?
Yes, right. Great.
Yeah.
Okay, so this is a core valve, and you see color-coded the video densitometry, and you could see that there is clearly a paravalvular leak. At the bottom here, you see the two time density curve, one in the aorta, the other in the outflow tract. And in this case, the video densitometry was 18%. The next few slides, I will go very quickly, because just not explain, but show that we have carefully validated that in vitro, in animal model, in human, echo, MRI, and look at the prognostic value. Here was the early days of the validation in vitro. You could see the paravalvular regurgitation was created by a deformation of the valve using a screw to compress the valve, and then in this mock circulation, we could look very carefully to the forward flow and the reverse flow in blue, 12% of regurgitation, 24, 41. You see at the bottom the injection in vitro, and also the color-coded assessment of the video densitometry, and at the very bottom, the time density curve. Then we went to the animal with a pretty nice ID. We used a femoral wall stent of different size. We opened it in the valve of the animal, but we did not pull out completely the sheet, so you could retrieve the wall stent and calculate the transvalvular aortic regurgitation. You could see we implanted the 5 millimeter wall stent, 6 millimeter wall stent, the 7, 8, 10, and every time we have the hemodynamic assessment, you could see a massive aortic regurgitation, and then validating the regurgitation. And what is interesting is that we had the good validation just with 8 ml of contrast in the aorta, synchronized or not synchronized. Then we went to the patient. That's the work that we did with our Brazilian friend. That's the transthoracic echo. The area under the curve is pretty good for assessment of moderate or severe. 0.84, you see that the cut point is 0.17. That's a very important number to remember, because an angiographic regurgitation of 17% correspond to a moderate or severe regurgitation as defined by echocardiography. Then with our Japanese friend, we went to the transesophageal echo, and there too, the area under the curve is pretty good, 0.88. So we were quite pleased with these two assessments. Then thanks to Professor Suleiman, we went in contact with Wahab in Segeberg and validated the video densitometry versus MRI in 135 patients with a reasonable Pearson coefficient of correlation. And then again, with our Brazilian friends, using the registry in Brazil with a follow-up of almost 4 years, we showed that this regurgitation of less than 17% has a good survival of 68%, while a regurgitation of more than 17% with the video densitometry has a very bad prognosis at 4 years, a survival of 39.5%. Then something very interesting that we did also with our Brazilian and published in the Archive of Brazil Cardiology is the impact of post-dilatation when we have a regurgitation. You see here before the post-dilatation, 20% of regurgitation with an Edwards. And then we did a post-dilatation, or at least my friend in Brazil made the post-dilatation and reduced that to 6%. And you can appreciate on the curve at the bottom, the time density curve, the dramatic change in regurgitation. By the way, in these 61 cases out of a quite large series of Brazil, we reduced the regurgitation from 24% to 12%. You see here the threshold of 17. Many of these patients were below the threshold, and then their survival at 4 years is 19%. But when we could not correct the paravalvular regurgitation, staying above the threshold of 17, then the mortality at 4 years was 34%. Then we went to 5 centers and 3 continents, all good friends, in Segeberg, in Germany, in Rotterdam, of course, Montreal, Yamaguchi, and Amsterdam. And one of the issues with this technology is that since we are looking at the regurgitation in the outflow tract, you may not have the superposition of the outflow tract. Oops. What happens here? On send. Go back here. That's the pleasure of the Zoom and transmission and everything, but I think we will fix it. Yeah. Okay, let's go back to, yeah, maybe the green one. We were here. Yeah. Can go there, maybe. Go there. Okay, so we are back in track. So that was the multi-center that you see, and you see here the over-projection of the outflow tract with the descending aorta. So you have to rotate a little bit the X-ray gantry to get the outflow tract not superimposed to the descending aorta. It's not difficult to do. Basically, you can look at the catheter in the descending aorta, ascending aorta, and you will get a good assessment. We call that the 10th rule because it's a fellow of Carl Schultz in Australia who has developed that. And you can do that in a much more sophisticated way, a la Piazza, I would say, and find a position where you have 2 things that you want to have. You want to have the 3 cusps aligned, that's for the operator, and you want to have no superposition of the outflow tract with the descending aorta. And if you look at the so-called S-curve, it's easy to find. If you do that, the acquisition, the feasibility of analysis jump to 95.5%. Now, we have the technique now online with Philips, and we have done in Amsterdam the OVAL, online video densitometric assessment, aortic regurgitation. Amsterdam were using the Edwards Ultra, the last version. And as you could see, they used the Heart Navigator with this complex superposition of the multi-slice CT scan and the live video densitometry. You don't have to make that complicated things, but of course, Philips is the inventor of the Heart Navigator. But you see that the feasibility of the analysis in Amsterdam in one institution was also very good, 92%. This is the key slide of the presentation. This is published by Rodrigo Modelo when he was a fellow in Rotterdam. It is in JAC intervention. As you could see, we have analyzed 7 different valves. Today we have 13 valves, including the Chinese valve, Venus, Taurus, Vitaflow, and other. And at that time of the publication, the Lotus was, of course, the number one, with only 2.2% of moderate or severe regurgitation, and then 19% of mild regurgitation between 6 and 17, and then 78% none of trace. And then you see the other valve, Evolute Pro, Sapien 3, Evolute R, Sapien XT, Accurate Neo, the first generation. We have now the second generation, which is doing very well. And the core valve, Historic, which was the highest percentage of moderate CV. You can see here the cumulative curve. This is the Lotus that unfortunately we don't have anymore. In blue, I put together the Evolute R, Pro, Sapien 3, and XT, and Accurate, and then the historical core valve, which was with a quite high regurgitation percentage in absolute value, 13%, almost 14% of regurgitation, while the Lotus was the best with only 3.5. The other were around 7 to 9. Now here comes the Myval. We have heard everything, and we got the consecutive series of 108 patients that we did compare with the Sapien 3 and the Sapien XT. And as you could see, we were very pleased to see only 2.8% of moderate and regurgitation. Then you see the mild, 48%, and none at all, 50%. And that is somewhat, if you look at the cumulative curve, very close, but somewhat superior to the Sapien 3 and the Sapien XT. And if you look at the absolute value of percentage of regurgitation, it's 6.3 with the Myval, 7.6 with the Sapien, and 8.8 with the Sapien XT. And you could see that at least there is a significant difference between the XT and the Myval. That has been, by the way, accepted by Global Heart, so you could read the paper. Now, the landmark trial, I think, has the right name. It might be a landmark trial indeed. You have the Myval. We have been talking extensively about all these intermediate size without mentioning the larger size. There is a good paper, I think, coming in International Journal of Cardiology, where we have about 1,000 multi-slide CT scan and the use of these valves undersized or properly sized, oversized. So that's very interesting. Then, of course, you have the Sapien series because you can use the very last generation, the Ultra. And then you have the Evolute series, where you could also use the very last generation, the Evolute R Flex. And this is an interesting randomization, 2-1-1, 2 Myval for 1 Sapien and 1 Evolute, a very careful statistical approach. By the way, the design paper has been published in the American Heart Journal. This is the structures. I think that the people involved are of very high quality. We have in the first place here the Corib Lab in the National University of Ireland, the team of Osama Soliman, Yoshi Onuma, myself, and Kawa. We do the echocardiography and the video densitometry. Marie-Claude Maurice in Paris with Sir will take care of the ECG. And in India, Mary Life is using 3 Mancio to look at the CT scan. So I think we are in good hands in this trial. It's amazing to see how many people has been in contact. I think that we are making progress activating all this site, also in Australia and New Zealand. So that's going to be very exciting. You have seen our champion today is Ignacio with some center in Belgium. We are step in Netherlands, sorry, step by step, we are recording. This is just the last slide. We have randomized 13 patients. I will not tell you who is Sapiens and who is Evolute and who is Myval. They are somewhere blind in these red dots. But as you could see so far, there are some which are borderline with 16%. That's the gray zone for 17%. Here you have the moderate and severe regurgitation by echo and by video densitometry. So it's very exciting. I think that with the anticipated expansion of TAVI with new device into low-risk patient, younger patient, difficult anatomies, there will be tendency and a race toward enhancement of the TAVI technology. Obviously, like in the stent 2 decades ago, we have entered the era of device versus device. The era of device versus surgery is gone. And in this device versus device, we will do a lot of randomized trial to go to the perfection. We are very pleased that the quantitative arthrography is fully integrated part of the assessment of the tree-valve. And the goal is, of course, to improve not only the peri-procedural and the long-term outcome. So this randomized landmark trial will tentatively fulfill this perspective. And we have, of course, working in close collaboration with our friend Danish, which is also running the trial that you have seen, but only Myval versus Edwards. We will have all three. Thank you very much for your attention. Once again, it's a real pleasure to see Alain in a good shape and Fausto also in a good shape. Yeah.
Thank you very much, Patrick. You were, as usual, superb. He's like a true scientist, as we know you for a long time. So we have Itamar from Natal, from here, from Brazil, Rio Grande do Norte, to make a question. If you wish, Itamar, please, welcome.
Yeah, thank you very much. First off, I'd like to say thanks to Barry and the 4 Valves team to invite me, especially for Licurgo and Marcio. Thank you very much. And I'd like to know, Dr. Serruys, a general question. Do you think it's still necessary to keep a heart team to decide these patients with aortic stenosis and calcified valve, or go directly all the patients to the interventional procedure?
Yeah, that's a good question. I don't think you can do a parallel with the coronary, because in the coronary, obviously, we're still struggling with 3-vessel disease and left main. So the need for the heart team in the coronary is there. I think it's also there in the valve, you know. I mean, you have seen the last partner, you see the curve suddenly converging at the end of the 2 years. You know that there is still some thrombosis on the valve. So I think we should not abandon too early the ARC team. And the ARC team is not only the surgeon, the ARC team is also the expert in geriatry, the pulmonologist. There's many other people in the ARC team. So I think the ARC team is something who has to stay, because it has another name, which is multidisciplinary approach. And you need the imaging and you need all kinds of things. So yes, the ARC team, in my mind, has to stay. Maybe the surgeon will have a less prominent role in that ARC team, but all the others are essential.
And also,
Yes.
Thanks to Dr. Alain Cribier, because almost 20 years ago, he had been in my city, Natal, and we performed 6 cases of mitral stenosis with valvotomy of Cribier. Thank you very much for your amazing brand. It's unbelievable how you decide, how you think to decide to do to the patient. It's unbelievable. You need a Nobel Premium of Medicine for me.
Okay, I accept it.
It's my opinion.
Great.
Thank you very much. And for this process, it's amazing. It's an evolution, for my opinion. Of course, we need to wait the randomized trial. But it's congratulations to Mary, because I think it's something different in this process. It's predictable, it's easy, safe, efficient, so we can work a lot of cases. And my last question to Dr. Serruys is, when do you not choose this process? No, it's not a good case to do. When you say, no, I'd like to use another valve.
Yeah, I think that's a very, very complicated question. I think that just not to talk about the Myval, but I'm thinking also technology like the Boston Scientific, the Accurate Nail 2. Obviously, because this is self-expanding, different from the core valve of the portico and so on. What I noticed, and Professor Soliman also, is that in Leipzig, but also in other places in Germany, with a very large practice. Don't forget that Leipzig is doing 1,200 valves per year. That's really a massive production, and probably the #1 in the world, by the way. And then it's amazing to see how they learn the device and then select properly the device. And I think that Professor Soliman would agree with me that that's the clinical flair, that's the extensive practice. But what is very encouraging is that in general, 2,400 valve of Myval has been implanted. And it seems that I would not use the term passkey, but it seems that it's a valve which responds many, many questions of the physician. And the fact that the physicians are using in Europe, but also in India and around the world, 44, 45, 46% of the intermediate size clearly indicate, and I think we will see that in the clinical result long term, clearly indicate the fact that you can tailor your valve, that you can work by 1.5 millimeter up or down. It's something which is going to be very important. We mentioned ruptures of the aorta, but I think that it's just a wonderful addendum to what we had already in practice. So, yeah, I think that it is a valve which is might be forgiving in many situations, including because.
Patrick, you said there are about 30 valves in the market. There will be, perhaps 30. Is that correct? 30. So, do you think there will be a class effect in the future of the future proceeds, in the future valves, like we saw in DES? Or we need always to prove, like you were doing in a study, like you did a landmark trial, compare Myval with Evolut and Sapien 3?
It's very difficult to give an answer. I think that a little bit like in the coronary stent for a long time, we were between the balloon expandable and the self-expanding. And today, if you see where is the self-expanding in the coronary, slowly but progressively it has disappeared, which is an interesting idea. I don't think it's something similar is going to happen with the valve. Of course, it's always a trade-off about the luminal area. I mean, the technology of the self-expanding is saying, yes, we have a better hemodynamic profile, but is that relevant? It's very difficult to say. I mean, 2.2 versus 1.8, does it make something essential in the long term? That's the question. I think clearly the implantation of the pacemaker is something we try to reduce, and then you have the other dilemma, regurgitation versus implantation of pacemaker. And I think that the one who can combine all three will be a winner. I'm impressed by the low rate of pacemaker with the Myval. I mean, I don't think I'm biased. I mean, that's the reason why we do the randomized trial, and certainly will be an important aspect. I already know for almost sure, to be honest, that the paravalvular leak will be very low because, all these analyses that you have seen, I show 7, but we have 13 valve now. It's done without any financial support. It's a purely academic activity so far. Now we are going to start to use the core lab to facilitate and make the service be a service provider maybe in the future. But so far, it was a purely academic activity. And to see that suddenly the Myval get close to the Lotus is a fact of life. I don't think that we will be surprised by the more measurement in the future.
Okay, great. Marcio, it's up to you. I think the time goes fast. We had a wonderful morning. Yes. We learned a lot. Thank you for the 4 valves and all the Merrill that organized this fantastic meeting. And it was a great pleasure in this Saturday morning here in Brazil. I mean, in the afternoon in Europe. And yes. We had all friends together. And the pioneers, Patrick and Alain, and also all the moderators with the nice questions, very intelligent questions that we need to answer. And Philip from Denmark, Francesco from Italy. Patrick, please.
I learned a lot today. I mean, I'm always amazed by the work of the Danish. I'm always amazed by the work of Ignacio, which is creative, and so I will have to look at his video 2 or 3 times to fully understand how he does it. But everybody, I really learned a lot, and I'm pleased to see that Brazil is there with this technology. Yeah, because don't forget that the whole drug-eluting stand start in Brazil and Rotterdam, so you have to keep the pace. Yeah.
Terrific, Patrick, terrific. And what I learned, the great scientists like you and Cribier are really humble. You were incredible and modern. That's what we learned. That we need to know. Even the young doctors, the young physicians, they need to learn with you, with both of you, how to treat the patient, how to do the right thing in medicine. That's what we are looking for.
I don't know if Alain is blushing more than me or if I'm blushing more than Alain. Yeah.
Okay, great.
Thank you. Thank you, Fausto. Thank you for your support today. Like the chairman, thank you, these 2 legends, Dr. Alain Cribier and Dr. Patrick Serruys. Thank you, the other presenters and all the panelists. It's a big pleasure for us, the 4Valve TV channel, our channel of structural heart interventions. And I'd like to say thank you for our audience. Probably today you have the biggest audience of our channel. And this transmission will be recorded in the YouTube. And who wanna be again is just to click again in our channel in the YouTube at while moment in when you want. And I'd like to say bye-bye. See you the next transmission. Thank you for you all. Bye-bye.
Have a great weekend.
Thank you.
Bye-bye.
Thank you.
Thank you all. Bye-bye.
Bye-bye. Thank you.